hematology residency at Monmouth Medical Center and Hahnemann University in Long Branch, New Jersey. He then completed his subspecialty training as a transfusion medicine fellow at Ohio State University and as a hematopathology fellow at the University of Texas Health Sciences Center at San Antonio. His expertise in these subspecialties provides a uniquely integrated diagnostic approach to hematopoietic disease processes. During the last 15 years, he has served as a faculty member of the UT Health Science Center and also as an adjunct professor at the University of Arizona. He has excelled as a national expert in the field of hematopathology, demonstrating proficiency in bone marrow, lymph node, and tissue-based hematolymphoid neoplasms. His tenure as the director of the flow cytometry and molecular genetics laboratory at the university has contributed to his extensive experience in cutting-edge testing related to a rapidly changing field of pathology. He is an outstanding communicator and educator in his field, and he has earned multiple awards for excellence in teaching and has mentored many pathology residents and hematopathology and hematology oncology fellows. He has contributed significantly to scientific work in peer-reviewed journal articles, authored textbook chapters, and has been the invited speaker at national teleconferences. Please welcome Dr. Aamir Ehsan.
Thank you. Thank you, Jeremy, for the kind introduction. It's an honor to be here, and thanks for the invite on the behalf for the organization committee. I don't have any financial disclosure or any conflict. As opposed to the Miami speaker, which was 95 degrees, I'm coming from 105 degrees in San Antonio. It's a great feeling to be in Denver. When I landed last night, it was raining. Never seen rain for almost a month in San Antonio. Pleasure to be here. So the topic I chose, gave a talk last year as well, and I'm happy that there's a bone marrow workshop right after this, which is very timely. What I can emphasize is being a hematopathologist, looking at performing the bone marrows, looking at the slides, doing the flow cytometry, reading cytogenetics and FISH, and now the NGS. We have come a long way. Bone marrow biopsy at the bedside, now to the Basepair. We are talking about NGS on most of these samples based on the clinical history. So it's really the art that you have practicing all these procedures that result in a lot of scientific data. So you're not only doing bone marrow biopsy, you are really writing and working on a treatment plan for the patient, because this is the only biopsy or only procedure what we do in the healthcare that has so many testing being performed. Most of the testing are being done are morphology and a few other things. So it's a very, very precious sample, and I'm going to take only 30 slides just to comprehensively cover the very high points of bone marrow and how it really impacts the patient care. So basically 3 objectives. The first one is what are the common tests that we can review doing the bone marrow and downstream. And these common tests are not only common, they are very comprehensive as well as very detailed. Discuss the common used terminology in the reports. Sometimes we take the terms and terminology very granted. These terminologies are not even mentioned in textbook. I was writing one book chapter on bone marrow, and one of the editor asked me how you define the spicule. So the bone marrow spicule definition was not actually there, so I have to come up with my own thought to write the definition of the spicule, right? So there are going to be a few terminologies that we use in the bone marrow report that we'll be discussing. And the review of comprehensive hematopathology report that we call it 2020 report. We don't want one bone marrow and have multiple reports. There need to be a way of consolidating and integrating all these reports in one-page report. So at the end of the day, there is so much knowledge and information, and our span of attention is very limited, and there's so much information coming. So the more integration we have in the healthcare, especially for cancer patients, the better for all of us. This is the concept of genotype and phenotype that we all hear every day, all the time. There are 2 undergrad students here showing in the middle that one person is saying that let's take the Chinese as major. It has such number of characters in the alphabet. And the second person is convincing, well, let's take it, molecular biology is very easy. It has 4 letters only. And now we know that even though these are 4 letters, how challenging and comprehensive knowledge there is. These 4 letters are, of course, 3 base pair in length. And when I was doing the molecular genetics training, sure enough, this is a book that I purchased back then, about 15 years ago. It was not easy to digest all this information, and also knowing that the evolution, millions of years ago, the evolution from chimpanzees to humans has been the history. We know that the genotype and phenotype is different, even though we share 99% of the genotype with our cousins, the phenotype is very different, right? Some people are 100% compatible. But I'm just making a point that don't go with the genotype, the behavior, how we act, so just like tumor is the most important thing. So that's why the DNA and RNA and the protein is an interesting combination that when I'll be talking about NGS. 15 years ago again, go to ski at Keystone every year with family, and that was my first time I was driving on Highway 70. And this was a picture taken by myself. This is not a Google picture. I took this picture, and there's definitely a town named No Name on I-70. And it's a town only comprised of 117 people, according to 2020 census. And the state, there are multiple stories, but the state sent out a letter to the villagers that come up with a name, and sure enough, majority of people say, well, let's have No Name. So it's close to Glenwood Springs. It's exit 119, right on Highway 70. The reason I'm showing this is if you have seen, I'm sure all of you have experienced the FAB classification, right? It was very easy, very simple. You see an R rod, you can call it AML. Now you have medical students and PA students and fellows and standing. You show them R rod, they still would like to have the flow data to confirm it's AML, right? So we are drifting away from the basic knowledge, which is so important, and the FAB classification really emphasized that. At that time, we were clinically very sound, morphologically very solid, and we have limited data, but we really rely on our eyes, what we see under the microscope, and have limited tools. Moving forward, science has been evolving and changing for the better of patient care. We have WHO classification that we have been using in the past, and now you have seen the interesting debate and conversation in the literature about ICC classification. A lot of overlap between WHO and the ICC, but there are still some differences based on genetic profile and things like that. But the key thing I'm trying to emphasize here is there are still going to be diseases with no name, right? And we are learning with new technology that we are going to be assigning new leukemias and stuff like that. 10 years ago, or maybe more than that, the AML M0 was not there, right? We used to call it ALL because all the stains were negative. And as we have more and more science coming, we are going to be naming those unnamed that have not been treated in the past. So I think those villagers were smart when having no name back then in Glenwood Springs. So this is the key slide, which really come down to the core concept of NGS, the PCR, the flow, and all the things that happen. So here you can see the DNA, which is a massive genome, and there are multiple mutations present on the genome from this side all the way to other stream. We cannot detect all the mutations, and scientists hope that we can detect the RNA. Remember the phenotype-genotype correlation? We hope that we can see the RNA because the region of the DNA has been sliced out, and we can look at the smaller molecule relatively. Eventually, we would like to see the mRNA or the protein, because bottom line is the protein is extremely important, whether you are making a diagnosis, whether you are treating the patient, or whether you're predicting the prognosis. For example, BCR-ABL is a protein, is a chimeric protein, and it's coming from translocation of 922 resulting in a protein. So we don't go back into the DNA and see where the mutations are. We just look at the bottom line, which is the phenotype expression of the disease. PML-RAR, again the translocation, multiple breakpoints happening in the translocation, but we have found the protein, which is the key thing in making the diagnosis and giving ATRA, right? ALK protein, which is anaplastic large cell lymphoma, 2-5 translocation. Probably not interested in looking at all the mutation, but we are looking at the protein at the immunostain level to make the diagnosis. So the scientists are more and more interested in identifying the protein that can be targeted, that can be treated, diagnosed, prognosed, and then you can go the reverse transcriptase and do all those kind of other studies on the back end. Science and business, we have been to ASCO every year, massive information coming. We are always getting challenged by, we know that this is the right thing for the patient. We know that this is the right procedure, and we know this is the right treatment. Exception exists. There are a few people who are practicing out of the line, and that kind of have led into the pre-authorization concept. But the data is numerous that pre-authorization definitely delay patient care and stuff. So rather than prospective looking at the pre-authorization concept in the testing procedure and treatment, it would be nice to have a retrospect audit based on the tools that we have to monitor what's going on in the healthcare. And that's what the ASCO have been championing to the Congress, to relook at the whole concept of pre-authorization and the medical necessity. When Jeremy and Corey, they are doing the bone marrow, like 12 bone marrows on one day, the decision needs to be made at the bedside, because these samples are not going to be obtained later on. So looking at a very brief history, back in 1953, it's not just 70 years. In 70 years, the first double helix model was described by Watson and Crick. Moving forward, 1993, Dr. Karis Mullis, driving on a California highway, envisioned this benzene ring, all these snakes and stuff like that, making a benzene ring, and then they got the concept of the PCR reaction amplification, because before it was all Southern blot analysis. Nobel Prize winner for that. Now the next generation sequencing. So what are we trying to achieve with all these kind of things? Basically, we are trying to achieve three things. One is we can make the diagnosis based on these genetic studies and tests. The example is I just gave BCR-ABL, PMLR, and SF3B1, ring sideroblast, MDS, right? The second thing we're trying to achieve is treatment, right treatment based on the pharmaceutical approach, targeted treatment, and now NGS back then used to be getting results within 21 days, almost a month. Now we are getting results back sooner, within 10 days, and the need of knowing NPM, FLT3, IDH, IDH1 and 2 mutation within 7 days, right? So the technology is getting better, the answers are needed quickly, and the information is needed for the second person, which is the treatment. The third thing is prognosis. Unknown, good prognosis, bad prognosis. Anytime we all talk to the cancer patient, what is the question they ask? Why it happened to me, right? Had I known this before, is there any screening? What can you do to make the diagnosis, and how are the treatment available, and what is my prognosis? So basically, whatever we do is really focusing on these three things. Many unknowns that were a few years ago has either becoming a good prognosis or bad prognosis, right? So people think that, we only, even at this time, we know the 5 or 6% of the human genome. We don't know 95% of the genome, and some people call them like junk DNA. But now we know that what we don't know does not mean that junk DNA is unknown, right? And more unknown are becoming known these days. So what do we do with all these massive data coming and all these esoteric testing? So I just gave an example here. A person decided to start up a chicken farm, so he buys 100 chickens to get up and running. So this is all like you give up permission from your executive leadership, go and do and start some sort of testing or business or laboratory. A month later, he returns to the dealer to get another 100 chicken because the first lot had died. The experiment did not work. Another month passes by that he's back at the dealer for another 100 chicken. I think I know where I'm going wrong, he tells the dealer. I think I'm planting them too deep. So the tool need to be used effectively, and it's a common saying in English, a fool with a tool is still going to be a fool, right? So it's very important how we utilize all these NGS data, all the information is available, but it all starts from this bone marrow biopsy, which you'll be having a workshop, right? So it's very, very important, which I'll be talking about next few slides, how we can effectively take the advantage of all these samples. Common indications. If you look textbook, there's going to be hundreds indication of doing a bone marrow. But at the end of the day, these indications are being categorized in group categories, right? So you have diseases or category of cytopenias. And all the cytopenias, whether you have anemia, leukopenia, thrombocytopenia, biocytopenia, or pancytopenia, everything, most likely going to be indicated for working up MDS. Most likely. Of course, there are other reasons. Then you have proliferation, high RBC count, high white cell count, and high platelet count. All those are kind of lumped together under cytosis for myeloproliferative neoplasm. And the third one, of course, the big one is acute leukemias. We don't know whether we are going to a bone marrow procedure, this is acute leukemia, but I'm sure that all of you have experience. You can see the CBC and you can see the look of the patient and you can do the biopsy and just going to the needle, you can feel that this is going to be myeloma patient or fibrotic or, it's experience. So a common indication, of course, is acute leukemia, that the bone marrow is extremely important. Lymphoma is a staging bone marrow, and it's important for two reasons. One is not only you are making the diagnosis, but also prognosis. Is it stage 4, not stage 4? Sometimes you see lymphomas in the brain or lymphoma in the retroperitoneum, which is very difficult to get. Rather than going in there, you just do a bone marrow, and if the bone marrow is involved, not only you are making a diagnosis, but you're also staging at the same time. And it happens quite often in the clinical medicine that can we get the bone marrow and get both answers. Plasma cell disorder is a wide spectrum of the disease, from MGUS all the way to multiple myeloma, common indication. Non-hematopoietic tumor, there are clinical trials and there are some treatment protocol based on staging purpose of the bone marrow. The common one is germ cell tumor of the testes or other site, that the bone marrow is indicated for those. And sometimes you are caught by surprise that you went in for hematopoietic tumor, but what you get is non-hematopoietic tumor like solid tumor, breast cancer, lung cancer, or germ cell tumor. Of course, I have not listed infectious disease, but infectious disease is either part of cytopenia, most likely part of cytopenias, in there. In the transplant, we do, bone marrow for transplant purposes, pre-transplant, and after certain days of transplant. So these are really the common indications of doing bone marrow. Now, this is one of the key slides, and then rest of the slides are going to be following it, and then we'll use the terminology. Morphology, what are the common tests I will do? Morphology, and still morphology is the gold standard. I gave an example of the OROD a few slides back. We are not going to change the diagnosis based on the data that's coming and the morphology is not making sense, right? I gave a good example that if an elephant walks into the room, it's an elephant. If the elephant is barking, I'm not going to make the diagnosis that this is not an elephant, this is a dog, right? This is an aberrant, an abnormal attitude of the characteristic of an elephant rather than changing the diagnosis. So what you see is the morphology, and that's the gold standard. What you experience unusual is the behavior of the cancer, and the cancer don't read textbooks. It's just the way they behave, right? So when we use the tools like flow cytometry, cytogenetics, FISH, molecular, including NGS and culture sometimes, we are making sure chemotherapy is being given. We need to be 110% sure whatever diagnosis we are making on the morphology is making sense. We don't want to overdo the things. We also don't want to underdo the things because the patient has undergone the procedure. How you keep a balance is, of course, learning, experience, talking to experts, and taking notes and stuff like that, and be abreast with the technology. So we'll try to address those briefly. What is the appropriate collection of the bone marrow? And this is a common, of course, question that we have: the lavender top tube, the purple top tube, and I have listed there that you can easily do flow cytometry, cytogenetics, FISH, and molecular, pretty much everything except morphology. I'm talking about the biopsy sections. Of course, you can make the slides and you can review the thing. So the first thing better is to go in and take the lavender top tube, so you can do all the testing using the lavender. If you do the green top can also be, you can do the molecular these days as well on the green top, but the common test you can do on the green top, cytogenetics, FISH, and flow. Both colors are fine, but prefer to have a green top first and followed by purple top first, followed by the green top. Now, the third thing is when you get into some additional samples, or if it's a dry tab, or if it's a tissue. Most of the time you're not dealing with tissue like a lymph node and stuff, but this is a RPMI solution, which is not a fixative, it's a preservative. So you can do the flow cytogenetics, FISH, and molecular on that. Formalin, well known that you put the clot and biopsy. You can pretty much do morphology, FISH, and molecular. You cannot do cytogenetics on formalin fixed tissue, and you cannot do flow, even if it has been put in there for a few seconds, because the cells are just kind of rapidly fixed. Common problem is a dry tab. I'll be talking the causes of dry tab. And if you get a dry tab, it's always a good idea to have a second core biopsy obtained. So one can go in morphology, the other can go in saline, and then we can do rest of the samples, rest of the testing. This is what happened in the lab, and this is also interesting. When we offered the bone marrow clinic program, the trainees see all these kind of steps, and once you have the visual of all these steps, then you can make it a better judgment at the bedside. So when you're giving us the bone marrow biopsy, the first step, so from top left you can see it's being grossed in. We take the measurement and we put into the cassette. The next slide, the next picture is a processor. The certain chemicals need to go through the process. It takes like 4 to 6 hours. The next step is someone is taking the tissue and embedding it. The next one is someone is cutting it. This is the ribbon that you can see, right? Then the staining on the side, and these are the slides that are stained, and the pathologist is reading the slide, right? You must have seen, well, I work at the lab on Friday. They don't want me to do the bone marrow because there is no one available on Saturday to do it, right? I mean, we know that most of the medical emergencies happen on Fridays. So it's important, the logistics need to be discussed at the facility, it's important that Saturday processing, even like half day, but again, it depends upon your volume and logistics and things like that. But just to give you perspective, what happened in the lab when you are doing a bone marrow. So if you're on Friday, maybe you can have a cutoff at 1 o'clock. 1 o'clock or 12 o'clock, that will give them enough time to do the process, or come up with some strategy. But of course, we are open 7 days because we know that most of our samples are actually coming on Saturday because most clinics are happening on Friday. This is another important slide. I just want to take a minute or two to go over the slide, so bear with me. CBC and peripheral smear is extremely important part of the bone marrow workup. As a hematopathologist, we are looking at bone marrow. We are fortunate at our facility that we do get CBC and we do get peripheral smear. But I have talked to my colleagues that in an outpatient setting, not a hospital-based setting, an outpatient setting, the CBC and peripheral smear is not provided. It's important, just like X-ray and a CT scan go hand in hand, the bone marrow and the CBC and peripheral smear goes hand in hand. The next one is the bone marrow aspirate. So on the top left, you see the very dark purple area. Those are spicules, and we cannot go into the spicules and read the cells. We have to go away from the spicules, and you can see the cells are kind of nicely spread out. So if you don't see those spicules, you don't see that many cells around, and that leads to lack of spicules or hemodiluted bone marrow. So the hemodiluted bone marrow will be more like a peripheral smear because there is no spicule, no cells around. To overcome that, most of you are very well experienced, and when you get a hemodiluted sample or a dry tap, it's most likely a diseased bone marrow. So what we do is we definitely do the touch imprint. On the core biopsy, you touch with the slide, and you're doing the same thing, try to understand, I cannot get the sample, it's a hemodilute, but my touch imprint is as good as going to be aspirate. So that's the reason of having a touch imprint if there's a lack of spicule. The other thing, lower left, is the particle prep that we used to do at the university, that we are taking the bone marrow, leftover bone marrow, and we used to filter it, get rid of all the fat and everything, and we used to make a particle prep. It's kind of different way of looking at the cells, right? The next one is the clot. You are all familiar with the clot, and the next one is the biopsy. So common question get asked, why clot versus biopsy? We know that biopsy goes through the decalcification process, and the decalcification process is a pretty harsh process on the cells. So we cannot do certain tests like FISH or molecular studies on the decalcified tissue, but we can do FISH and molecular on clot section. That's the reason of making a CBC and a peripheral smear, having a good aspirate. If not a good aspirate, have a routine of making touch imprint, because you never know how the aspirate is going to be. And you don't need to make the particle prep, it's just an added academic slide, but definitely clot and biopsy, and that's the reason of doing all these kind of multiple things. So what is immunophenotyping? You must have heard the word immunophenotyping. Immunophenotyping is basically nothing, just antigen-antibody reaction. So when there is an antigen-antibody reaction, you need to know how to monitor that. So if you put a color on the slide, it's called immunostain, and if you put a fluorochrome in the cells, it becomes flow cytometry, right? So immunophenotyping is looking at antigen-antibody reaction using flow cytometry and immunostain. Flow cytometry, the difference between the two, flow cytometry is can be done on fresh sample, not on formalin, and immunostains can be done on formalin section. Hodgkin's lymphoma is an exception. Hodgkin's lymphoma cannot be diagnosed by flow. Hodgkin's lymphoma is diagnosed by immunostains. So there are certain markers which led to the CD. What are CDs? CDs are cluster of differentiation, right? So if I would like to think about this analogy of leukemia, lymphoma, we are looking for the diagnosis of leukemia, normal, abnormal. If I would like to identify one smart person in this room, I know who that smart person is, but if I would like to identify, I'm going to use a marker that says, well, this meeting is happening in Denver, so I'm going to tag the whole panel with Denver, because meeting is happening in Denver. So my first CD marker is going to be Denver. I'm going to tag the second antibody, this is APAO meeting happening, and I'm going to tag there are multiple sessions going on. I'm going to have another antibody to tag the room, and I'm going to tag all the people, like human body, and then keep adding more and more markers to get the smartest person in the room, right? So this is what we are trying to do by flow cytometry. We are coming up with about 25 to 26 markers to not only diagnose subtype and get the most information, and 26 markers is a pretty average panel that we use in the flow cytometry. So you get the rapid diagnosis within 2 hours of doing the bone marrow once the lab had received the sample. So morphology. Again, showing you different things, how the cells look different. And we do certain stains. So the top one is the H&E, and the bottom one are the immunostains. So if you can see, this is a patient with multiple myeloma. And I'm showing you the plasma cells here and the plasma cells here. They look very different, right? So when we go to a party, we are dressed up nicely, and when we go to a gym, we look different, right? So this is the concept here, that when you're looking at the plasma cells on the aspirate, they will look totally different. When you're looking at the cells on the biopsy, they look totally different. And we are trained of looking at all these cells in a different environment based on the process of the sample that I talked about. And we use it for different purposes. So this brown staining, which is CD138, is for plasma cells. And sometimes it will be difficult for us to look at, so we make sure that we are not missing anything. So we add a marker, which is CD138, and we get surprised, wow, that's a lot. Normal bone marrow should not have more than 1 or 2% plasma cells, it's a lot. And then you do kappa and lambda to make the diagnosis of clonality. Because we could not get the sample for flow, we are doing another way of using antigen antibody by immunostains. This is a flow principle, a very basic cartoon of looking at the flow concept. Now we can do like 10 color flow cytometry and 12 color flow cytometry. And what does it mean really? If there is a tumor here, if there's a cell here, I'm just going to strike these cells with a laser beam, and based on the size of the cell, it's going to deflect it into different channels. And based on the antigen antibody reaction, it's going to deflect into different channels using different color. So to make the complex understanding very simple is we need to have a cell, tumor cells, and we need to have an antibody against the cells, and those can be tagged with different color, and different color based on the wavelength go into different channels that we are monitoring. And that's basically what the flow cytometry is. And you can read the flow with me. I'm sure that when you go back, you can easily read the flow. So this is a flow. There are 4 quadrants: top left, top right, second, third. So 1, 2, 3, 4. And any antibody which is in these quadrants are going to be positive. So there are 2 antibodies, CD19 and CD5. CD19 is a B, and CD5 is a T cell marker. And there cannot be a normal cell that can have both B cells and T cells. And there are 2 diseases that have expression of 19 and 5, and that's CLL and mantle cell lymphoma. So you add another antibody, and these are clonal, kappa clonal, not lambda. So you add another panel, CD20 and 23, and this cell population is 20 and 23 positive, right? If 5 positive population is 20 and 23 positive, it's CLL. If 23 is negative, it's mantle cell. So if I show you this, no 23, this is a mantle cell lymphoma. If I have a CD10 on these cells, it's follicular lymphoma. Burkitt's lymphoma, diffuse large B-cell lymphoma. 10 is only positive in these 3 tumor cells: Burkitt's, diffuse large B-cell, and follicular. If I see strong 20 and 25, it's hairy cell leukemia. Okay? If I see 10 and 34 together, it's B-cell ALL. And if I see, this is 10 and 34, this is 10 and 34, B-cell ALL. And the last one is the T cell. Any CD marker less than 10 are T cells. And you can see here, this is CD2, so we are dealing with totally different population, CD2. So one slide, crash course of flow, you can look at the data and you can at least talk to the hematopathologist. I did the flow on this patient. I think it's acute leukemia. Can I look at 10 and 34? I have not shown you myeloid markers, but of course the myeloid markers are there. But these are very common ones. So what are the cytogenetics terms that you hear on the report? Metaphases. Metaphases are the cells that are multiplying, that are dividing. So if the cell is coming from Arizona all the way to New York, the temperature in Arizona these days is 120 degrees. The cells might not be dividing and dying, and you may get a normal cytogenetics. So we need to preserve these cells in an ice pack so the cells are happy. So you have seen that if you're working in a hospital-based setting and the cytogenetics lab in a hospital-based setting, you will see more and more abnormal cytogenetics because the environment is controlled. Everything is processed within. But when you're working in an outpatient setting, you do a bone marrow in Minnesota, the sample go to Florida, they don't do cytogenetic to a reference lab, they send the sample to California. And you can imagine that the shipment, and you might end up getting more normal looking cytogenetic cells. So metaphase is important. So that's why it's important to see how the samples are flowing and what results you are getting. Karyotypes. The cytogenetics people are going to be looking at the analysis, and they look at 20 cells, they analyze, and they karyotype. They take the chromosome, they put into the map. That's called karyotypic analysis. You must have heard the term trisomy, monosomy, clonal. It's the definition of cytogenetics. You cannot have like X many cells and you call it trisomy and X many. There is a definition. Then you need to have 2 cells in a sample to call something trisomy. You need to have 3 cells to call something monosomy. So if you have a loss of 7, is it in 1 cell or 3 cells? If it's in 3 cells, yes, it's an abnormal population. So there is a definition of clonality by cytogenetics. Translocation, we all know, piece from one chromosome go to another, and things like that. Cryptic translocation is something that we cannot see with our eyes under the microscope for cytogenetics. So you have to have a big 5 megabase loss to see something by cytogenetics, and that's why we use the word cryptic translocation. You have seen a lot of babies and a lot of cancer where the cytogenetics is normal. The reason is most likely it's a cryptic that we cannot detect by cytogenetics, so we need the help of NGS and things like that. This is a typical, karyotype spread that I have shown you just to demonstrate how we do the banding and stuff. And this is a case of showing 15, 17 translocation. To your eyes, or to even to my eyes, it's very difficult, not normal, right? All I can see is, well, there's an X chromosome and there are 2 X chromosomes. But these cytogenetic people are so well trained, and now the AI is becoming available to look at all these chromosomes. But just to let you know that when I was practicing HemePath or fellowship, there were like 20, 25 cytogenetics programs in the whole country. Now, can you guess how many cytogenetics programs are there? Only 2. One at Mayo Clinic, other at MD Anderson. So we need to, train these people because cytogenetics is not disappearing. It's an important field to exist. But we are challenged these days by having experienced cytogenetics tech. FISH is another technique. FISH is really, we cannot say that please do FISH. We cannot, we need to tell them what need to be fishing for, right? So we have to tell the lab, please do FISH for 15, 17, please do FISH for BCR-ABL, please do FISH for this and that. So the good thing is to say, well, let's do cytogenetics. Cytogenetic samples are saved for 6 months, and you can always add the FISH later on. Or if you really know that this is, I want to rule out ALL, so you can say ALL FISH panel. I want to rule MDS, those kind of things. So FISH, if there's a door handle on this door, I need to target that door handle to pick up the abnormality. That's what the FISH is, right? So need to be pretty precise and anything. So there are different probes. I don't want to go into the detail, but there are different probes tagged different color. They're specifically looking at the centromeric of the probe, the locus of the gene, the whole panes, and things like that, right? So if I'm using chromosome 5, which is often seen in MDS, and the chromosome 5 centromeric probe, so I'm going to get 2 signals, chromosome 5, right? But if I get 1 signal, that I know that 1 chromosome is completely lost, right? So that's how we read the FISH signals. And this is another way of looking at the FISH signal, green and red and orange. And if it's a color, and if red and green combine, you get a yellow color or signal. That's how you see the concept of translocation and the breaker point and things like that. Terms in the report, you are familiar with a dry tap, hemodiluted, crush artifact, subcortical bone, insufficient for diagnosis, aspiration artifact, lack of mitotic activity, DNA, RNA sequencing. and extraction. So dry tap we already know, a poor aspirate. Hemodiluted we know, no spicules. Crush artifact, if you're not gentle with your biopsy, it can give you a crush artifact. So we need to be more gentle. Subcortical bone, we are superficial, and when you get a subcortical bone, there is hypocellularity normally below the bone. So we don't want anyone to call aplastic anemia if the pancytopenia is there and the sample obtained is subcortical bone, because subcortical bone by definition has less cells. Insufficient for diagnosis, we try not to use that term because it means obviously you have to go back and rebiopsy, but in those cases where absolutely very poor sample, then that's the term we use. But most of the time, we can come up with a diagnosis by touch imprint or aspirate or biopsy or flow and stuff like that. Aspirin artifact is something that you take the samples out and the core biopsy is going to see emptiness where some of the red cells are there. We were talking like last night that aspiration artifact is pretty much present in most of the bone marrow, but that's only a minor part of it, right? It's not going to impact the diagnosis, but if it's universally present in the whole core, then of course that's a problem. Lack of mitotic activity, if the cells are not going to grow, we cannot do cytogenetics because metaphases is required. And now, sometimes we don't know where we need to have a NGS or not. So the easy thing is to extract the DNA and RNA, and you can do the testing downstream. Other terminology that we use, we already talked about next generation sequencing, DNA mutation, expression profile, protein expression, which I was just giving an example of how the tumor behaves is the expression by RNA, how the tumor is inherent and present like a monkey is the DNA, and the behavior is the RNA expression. So we need to study both. Sometime when you have sometime when you have a dry tap and the patient has a pancytopenia, you don't have any sample for NGS testing. That's where we use the term liquid biopsy. Liquid biopsy is nothing, just the peripheral blood that we know that the tumor cells are not circulating, but now we know that these DNA fragments and RNA fragments are cell-free and they're coming in the blood. And we use the term liquid biopsy to detect those cell-free DNA and RNA. In heme malignancy, it's used for those when you have a dry tap, you don't have good aspirate, and you have a pancytopenia. So liquid biopsy is indicated. In solid tumor, breast cancer, lung cancer, it's a common test to monitor whether how the patient is relapsing or how the patient is doing. It's a blood test by NGS. So how to approach a dry tap is, of course, other than the technical, the diagnosis is most likely going to be leukemia, lymphoma, neoplastic fibrosis. Get the CBC and peripheral smear, hemodilute sample is going to be there. Touch imprint is going to be extremely important. And you obtain 2 cores, one for formalin, for morphology, and other for additional studies. Key thing, how do I recap all this data? And this is what the summary report is, what we call 2020. And you can see like 1, 2, 3, 4, 5, 6 reports are being consolidated all on one page. The patient had a variable cell marrow, has thrombocytosis, but not enough to make a diagnosis based on the morphology. Unfortunately, flow is not going to be helpful. Cytogenetics came back normal, fish came back normal. So if this would be like 10 years ago, it would be a descriptive diagnosis. Now, doing the NGS, we saw TET2, AXL mutation, and P53 and other mutations, so we know that this mutation happened in myeloproliferative neoplasm. Patient have a history of thrombocytosis, so we can call it ET, essential thrombocythemia. So that's where the value is, and this is a nice summary report integrating all the reports on one page, and everything is making sense. Last 2 slides, clinical scenario, and now you start thinking, well, I have a patient who's 70-year-old male with pancytopenia. Of course, the indication there are many reasons, but often you think about cytopenias, MDS, bone marrow involvement, right? And if you get a dry tap, get 2 cores and do rest of the stuff. If you don't get a dry tap, nice bone marrow, then flow is going to pretty much give you the diagnosis along with morphology. So this was an example of an MDS. Second case, 55-year with leukocytosis, thrombocytosis, anemia, most likely CML, myeloproliferative, BCR-able fish, those kind of things are going to be important. Third scenario, CBC with many circulating blasts, it's leukemia. The bone marrow has a lot of value, so pretty much doing every test because, all those tests are indicated in acute leukemia. Abdominal mass, a big abdominal mass, now with pancytopenia, most likely some high-grade lymphoma involving the deep masses and also involving the bone marrow. So, you expect a dry tap, do your touch imprint. It might be Hodgkin, non-Hodgkin. Flow is going to be important along with your morphology. No need of NGS, but again, based on the morphology. Multiple lytic lesion, take-home, of course, message is MSPI, multiple myeloma. Cytogenetics is not going to be helpful because myeloma cells are like roaches. They don't divide. You cannot kill them, right? Because they're not dividing. But from the pharmacy point of view, if you cannot kill them, you're not going to be dividing. So that's why the cytogenetics is going to be negative, and FISH has more value and NGS have more value. And that's why you cannot beat them too much with chemotherapy. So targeted treatment is a good option for multiple myeloma. The last slide is really the take-home message of the bone marrow and all these kind of things going on. Key thing again is morphology is critical for making downstream decision. Flow cytometry is the most powerful tool, can get the diagnosis within a few hours. Cytogenetics is needed for those cases where you need translocation and things like that. Make sure the cells are having mitotically active and metaphase and the causes and the reason for that. If you're doing these three things, you're home safe. You have secured the sample. Other things you can add on, like FISH, you can always add on. If you have a cytogenetics palette, you can add FISH within like 6 months or 3 months because labs typically save those palette. Molecular, you can always do a day or two later after making the diagnosis by the flow cytometry. That it look like acute leukemia, let's do the NGS rather than ordering everything up front. And the stains is also, pathologists are going to be responsible for doing the stains. So simple thing, morphology, cytogenetics and flow. If you have decent sample, you have done your job, and rest of the stuff is going to be decided later on. So I'm going to stop here. Happy to take a few questions. I wish I can stay for the workshop, but I have to fly to CAG. Thank you.
I just had a couple observations that I wanted you to comment on as well. Just some things that we'll probably touch on a little bit in the workshop as well, but some common things that I've seen in practice is that either delays the sample or causes problems when you're using an expired tube. So that you want to make sure you're checking the expiration date, because that you don't want to have to repeat a bone marrow biopsy in somebody if you use an expired tube. The person that's assisting you or yourself putting the wrong caps on the right tube, so you're using a green top tube and a purple, if you switch the tubes, that sometimes can affect the samples. Again, a lot of the things that he was talking about and that we're going to talk about, there's institutional preferences. So at my institution, they don't mind if you put the clot and the core biopsy together, but at another institution I worked at, they wanted the clot to be in one container and the biopsy to be in another. Recently we had a big, we have a lot of new staff, where the slides were not being sent dry, they were putting into the slide holder wet, and then the pathologist sent pictures of what it does and how it affects their ability to be able to read and look at the slides. And so that was another thing that I mentioned as well too. So, yeah.
Good, yeah, excellent. So just excellent point, very practical tips. Only thing about clot and biopsy together, institutional preference for sure, but keeping in mind that clot is non-decalcified, biopsy is decalcified, so if you're doing stains, either you need to carve out that block, or if you're doing some FISH or molecular, you need to carve that block out. But of course, it's an institutional preference.
Okay. Thank you again.